Our next speaker is Mary Armanios, Professor of Oncology at Johns Hopkins University. Mary has been instrumentally involved in the initial descriptions of telomere mutations in fibrotic lung disease, suggested we should call it different also, telomere-mediated. So Mary, our pleasure.
Thank you, Oliver. Good afternoon. It's a great honor to be here. You heard already that I'm trained as an oncologist, so if some of the things I mentioned seem strange, you can blame it on that, perhaps. I think the organizers in their wisdom highlighted the importance of genetics and understanding the etiology of pulmonary fibrosis if we're going to try to have a home run with this disease and its treatment. I'm hoping to tell you a little bit about the genetics. You've heard some how I became involved and how we think it's important for patient management and especially for approaching the treatment. And that's why this genetic session is nicely placed in the middle of our meeting today. So I came at this from the perspective of the telomeres, and these are the ends of chromosomes. And for a long time, it had been known that they divide successively as cells. They shorten as cells divide and eventually lead to a cellular senescence phenotype and cells dying when they reach a critical threshold. And that has linked telomere shortening to diseases of aging, at least hypothetically, and it seems that the most important link between short telomeres and human disease is lung disease, especially pulmonary fibrosis. Telomerase was discovered to explain why telomeres are maintained. It was discovered in a model organism from a very basic science perspective that, as you heard this morning from Dr. Lloyd, led to the awarding of the Nobel Prize. But for our purposes today, I want to point out that it has two components, a reverse transcriptase TERT and a human telomerase RNA component, which works together with TERT to elongate back telomeres. And TERT, as we found, is the most commonly mutated gene in human disease. Now, the importance of telomere length in organismal, in disease in particular, it came to me at least from this observation, and it was recognized that telomere shortening has impacts on survival initially in mice. And this is a survival curve of mice that are null for telomerase. And you can see that their survival successively decreases as the telomere length shortens. They're genotypically identical. They all lack telomerase. But the telomere length in these mice predicts how long they will survive. Paradoxically, you can also think about what would happen if we can elongate telomere length and what a great impact that could have if we could do that. The interest personally for me in this disease came from this family that Dr. Lloyd talked about this morning, a 3-generation family with multiple diseases, not just IPF. And this family showed the pattern that we had described in mice, where IPF showed up earlier and was more severe with each generation. And that gave us a clue that maybe in this family it was not IPF as we understand it, but something related to the telomere. And this was indeed the first family to carry a TERT mutation in association with familial pulmonary fibrosis. And as you heard, we found initially that, and subsequently my colleague and friend Christine Garcia found something similar, that a certain subset, about 10% initially of familial cases of pulmonary fibrosis carry a mutation in either the TERT gene or the telomerase RNA gene. This was hard to understand, I think, at the time, even for us, because folks who developed lung disease developed it quite late in life, and that made it very difficult to appreciate that this is indeed a genetic cause that they may have carried from their parents into adulthood. And this may be one of the oldest diseases that have later onset that are caused by a single gene disorder. We now know that the telomere pathway is the most commonly mutated in pulmonary fibrosis. There are 7 genes, and time will tell how much of this remaining pie will be attributable to genes in this pathway. Some of us think at least half of this pie will be related to telomeres and telomerase components. And you can see them here. This would otherwise be an obscure basic science figure that would not be shown in a meeting like this, but I think we're going to have to deal with this pathway, if we are to deal with the etiology of idiopathic pulmonary fibrosis, and as I'll talk in a second, related disorders, the mutations have something to do with the telomerase enzyme itself, its biogenesis, or its recruitment to the telomere. This has come up earlier, but I just want to highlight it here for the sake of our conversation, that we have heard about MUC5B, a common polymorphism that has and is associated with an increased risk of IPF. The risk of IPF in folks who have this MUC5B polymorphism is about 2 to 3-fold. For telomerase and telomere gene mutations that we're talking about, it's at least 500-fold. So it's a much, much rarer variant, but it has a much, much larger effect size, and that's important to keep in mind. And what I think is also important to keep in mind is that of all human diseases that we know of, IPF in particular seems to enrich for the greatest proportion of people who have short telomeres. There's no other disease that shows a pattern like this where individuals have abnormally short telomere length. This is a telogram with age here, telomere length here, and the normal range is between the blue and the red line, and you see that at least half the patients fall below this 10th percentile. One of the implications of this is the observation that we made a long time ago that folks with short telomere-mediated IPF seem to have a systemic disease. The disease is not limited to their lungs only, and they're prone to vulnerabilities in the bone marrow and the liver. And we have tried to think of this as a syndromic entity, in part to remember that these things might matter, and I'm going to give examples for why that is. The bone marrow phenotype associated with short telomeres historically was the one that was first described, and you'll see here on average, the average age of onset is in the 20s. In adulthood, IPF alone or in association with bone marrow failure seem to be the predominant defects. Most commonly, it is this alone, but this is clinically significant, as I'll show an example in a second. So I want to jump here and tell you that the reason the telomere is important is because it matters when we treat patients. And the most dramatic and drastic example is in the lung transplant setting. This was a first report of patients from all over the world who carried mutations in telomerase genes who underwent a lung transplant, and soon thereafter, after their bone marrow was challenged with immune suppressive drugs, they developed severe cytopenias. And these cytopenias were clinically meaningful because they led to infections. This is a gentleman who had an infection in his native lung after his right lung was transplanted, or they get infections such as CMV pneumonia. Since we and others have reported this phenomenon, there has been a bit of a controversy in the field as to whether you should identify and test patients pre-transplant for this abnormality or for this defect prior to transplant. And I think there has been the opinion that this could preclude patients from lung transplant. I want to offer the opinion that and the hope together that these observations in an era of genetic medicine and precision medicine can only lead us to improve the way we transplant IPF patients with short telomeres, with the hope of attenuating and even preventing these complications. Sorry, I'm stuck. If you can give me my next slide. So we do research and we organize meetings like this with hope of identifying a tool, a genetic tool or a molecular tool that can categorize folks either into long or short telomeres or some sort of categories that are meaningful. And I think we have the tools, as you've heard today, to identify and to recognize patients who may have an increased risk of certain toxicities and complications. And the hope is that if we know about this a priori, it would not be a negative stigma, so to speak, but it would help us to move this area of transplant forward. And we have certainly precedents of personalized transplant protocols in other parts of medicine. For this reason, about 7 years ago at Hopkins, we sought to try to figure out a way of making available a service to measure telomere length for clinicians for clinical use. And I'm going to just briefly mention that this service went live about a year ago. And when we determined that the normal range of telomere length in a Baltimore-based population, we found that it was remarkably identical to a population in Vancouver, meaning that the telomere length really has a strict normal range. And we can plot the folks that we have taken care of over the last few years on this telogram, and you can see that they tend to cluster in the lowest deciles of the population. As you go from left to right, there's a bit of a dropout for folks who have very, very short telomeres, probably because they developed such severe disease, as I mentioned earlier. The telomere length does not discriminate between which component of the telomere pathway is mutated, because all of these seem to have the same endpoint, which is short telomeres. But there is this remarkably excellent negative predictive value that can exclude this diagnosis fairly definitively. And similarly, the telomere length is not diagnostic of disease. It is diagnostic of the risk of disease, because in about a third or a quarter of these folks here who are in gray, they had the defect and they had short telomeres, but they had not yet presented with disease. But as you go from left to right, with aging, the prevalence and the percentage of symptomatic folks increases. So that leads me to show this graph, which was really remarkable to me, showing a correlation between the severity of telomere length, the deviation from median, so normal would be here, and this is how short the telomere length is from the median for a given age, with the age at diagnosis, and there seems to be a significant correlation. Sort of similar to the mouse experiments that I showed earlier. I'm not advocating that we use telomere length to determine and predict the onset of disease, but I think this highlights the potential power of this tool and of this genotype. Now, we measured telomere length using a technique called flow cytometry and FISH, or FlowFish, and if you come to our lab, we have plans to build a small aquarium to include fish. This assay is far more robust than a commonly based technique, quantitative PCR. I will mention that Dr. Garcia's lab uses quantitative PCR with high precision. I'm not aware of any other lab that does that. But the interlab validation that we showed between our lab and the Vancouver lab is the only one of its kind, and it really determines and sets this assay and this way of measuring telomere length as a gold standard for clinical use and for other folks to implement that and to use that just like we use cholesterol or something or other tools for determining disease risk. So why is it important to know about the variability of the quantitative PCR method? I want to mention this example because I think it's really clinically relevant. There was a study that was published last year that used androgens, which commonly, which are helpful for improving blood counts in children with bone marrow failure, that's telomere-mediated. And they used the qPCR method and found that there may have been an increase or a lengthening of the telomeres. However, a recent presentation from another group at the NIH, which I hope will soon be published, used the FlowFish method and found the exact opposite. And it's our understanding, in our field at least, that this is the gold standard and the telomeres do not change their length with the administration of androgens, and I will say here that there is no indication for using them for patients with lung disease, and in fact there are theoretical reasons why they could be considered very harmful. I want to just end by talking about the spectrum of telomere-mediated lung disease if I have time. When we were trying to understand how telomeres might lead to lung disease, we went back to the mice that have short telomeres that I mentioned to you, and we found they don't develop any lung disease de novo. But John Alder in my lab was there, and we decided to expose these mice to cigarette smoke, hoping that they might develop a phenotype. And surprisingly to us, they developed a different disease, emphysema. And I know I shouldn't talk about that. This is a pulmonary fibrosis meeting, but as I'll tell you, there may be some connections between those diseases, at least around the telomere. And what we later discovered is that there are some human patients with telomerase mutations that when they smoke develop emphysema, either alone or combined with pulmonary fibrosis. And what has been striking is in the same families we have studied, we found that people who don't smoke in general, they develop some sort of pulmonary fibrosis or interstitial lung disease. But in the folks that smoke, especially in women, they tend to develop emphysema either alone or combined with pulmonary fibrosis. Now, that's really important because classically, and I mentioned to you I'm not a lung doctor, but classically these two diseases have had distinct meetings and distinct understanding of their pathophysiology, but they may share more in common than we thought before. And the reason I mentioned that, and I'm sure Dr. Garcia will talk about that more in her discussion, is that when we look at families that have the same identical mutation in a telomerase or a telomere gene, or even in a surfactant gene, they seem to have a whole menu of pathologies under the microscope and even on imaging studies. So much of the classification of lung disease depends on imaging studies and still on histopathologies. The genetic findings so far over the last decade suggest that maybe these disorders are, maybe the microscope and the CAT scan may be fooling us at times, and that the DNA is the way to sort of understand what is going on in these families. And I'm sure Dr. Garcia will talk about that, and as you heard from Justin, it seems that the genetic diagnosis trumps the histopathology or the clinical features in many of these cases. And maybe one day we will, in our algorithms, include genetic evaluations up front and telomere length prior to doing a lung biopsy. And the reason I mention that is because I learned from my colleague, Dr. Sonia Danoff, and from other studies in the literature and from personal experience, that sometimes doing lung biopsies can be really harmful and is associated with a very high rate of mortality and respiratory failure and exacerbations in patients in particular with IPF. Can we use the genetic testing to bypass and to completely avert this potentially life-threatening toxicity, especially if the genetic testing may even be more informative? So I do see that the possibility, and we're very close to, I think, having a lot of evidence to implement a molecular paradigm in the diagnosis of IPF that I think could replace existing algorithms for evaluation with the goal of improving patient care. And that may be by avoiding lung biopsy, avoiding immune suppression, and as I mentioned earlier, anticipating lung transplant complications. I'll end with this example about how do short telomeres cause lung disease. In the bone marrow, short telomeres cause lung disease by depleting stem cells, and stem cell transplant basically cures the bone marrow disease in these patients. They eventually develop other complications. Could it be that stem cell failure might be driving the lung pathology in these patients, whether it's emphysema or other interstitial lung disorders? And I'll just show this figure. This is an experiment where we induce telomere dysfunction in alveolar stem cells, the hypothesized site of regeneration in the alveolar space. And here you can see that after 2 weeks, each stem cell creates an alveolosphere that is surfactant-filled that represents the regenerative capacity of that stem cell. But in the telomere dysfunctional stem cells, these cells are senescent and they can't divide. And the question therapeutically here is a really difficult one because we don't have a paradigm in medicine or science at the moment to make a stem cell like this regenerate its capacity to become like this. So even though we have made headway in understanding the genetics, I think the pathophysiology of telomere-mediated lung disease is one that really is humbling and that will take, I believe, an investment in understanding the basic science of the lung, as well as the nitty-gritty details of how the telomere and telomerase machines function. The challenges are, I think, obvious. Regenerative medicine is still in its early stages, definitely, especially in our neighborhood in the area of lung disease. Telomerase is highly, highly regulated and only elongates telomeres when cells are dividing, and the lung hardly ever divides. The lung disease looks different in these patients. As I mentioned to you, they may each have a different histopathology, even though IPF is the most common. So with that in mind, I think we have a call and a hope and an opportunity to think ahead, both in terms of immediate ways to consider therapy venues, but also in the long term of how we can invest in an infrastructure that can get us closer to treating the root cause if it is indeed stem cell failure. So I'll summarize. I showed you evidence, and you'll hear again soon more about this, that telomerase and telomere gene mutations are the most commonly defective genes and pathways in familial forms of IPF, and I will add, including also at least half of sporadic cases. This identifies a new pattern of disease and puts IPF on the map for a systemic disorder that, at least in some patients, is very clinically relevant, especially in the lung transplant setting. I showed you evidence that telomere length is not shorter or longer. It has a definable normal range that is now on the map, and it is the gold standard, and you can think of the aquarium when you want to remember this. In clinical settings, they will be defined, and I think in the diagnosis and pre-transplant settings, maybe two different places where we can use this right away readily, and it is available in this country. Genetic evaluation with telomere length should be considered in lieu of biopsy. This is my own opinion, but I think there's a lot of evidence that suggests this, especially in patients with short telomere syndrome features and in familial pulmonary fibrosis. I think this could avert deadly toxicities of lung biopsies and give us more information than a lung biopsy would. There are many, many hurdles to genetic testing, interpretation, and access, and that's a challenge for medicine as a whole, but also an opportunity, and I think that's why we're here. Thank you very much for your attention.